So what do you enjoy most about being the program director for the University of Tennessee Health PA program in Memphis?
My path through academia was, I knew I wanted to teach. I don't think I really wanted to be a program director when I started. It was more of I knew I wanted to teach. And then as with anything, you start to get to the point where you see the things that you want to do. There's something that I want to accomplish in my career as a professor. And sometimes the culture of the institution doesn't support it, or the program administration doesn't support it, and that's when you start looking inside and saying, well, what do you want to do? And so what I like about being a program director is that I ultimately get to guide the direction of the PAs, students that come out of my program, that I know they're going to have a very specific training set. I'm going to know that they're going to be versed in all of these things, that this is going to be their forte, and that if I want to do something different, I have the ability to be able to do that. Now, I use my faculty a lot. I mean, we have a lot of meetings and a lot of conversations around things, but ultimately it's conversations that I try to start and say, look, I want to do this. What are your thoughts? Do you guys think that this is a good idea? If you do, how do you think we should institute it? Because you guys are going to be the one teaching it. But this is where I think it fits into the grand scheme of things for a UTPA that is going to come out, and do you support it or do you not? And if not, let's have a conversation about it. So that's the main thing nobody else likes the other parts of being a program director. I mean, nobody likes surveys and data collection and statistics, and that's not the fun part. The fun part is being able to say, this is my program, these students are going to be coming out of my program, and for the rest of their lives, they're going to remember me as the program director of the school that they went to, and that's what I enjoy. I mean, I ran into half a dozen of my former students already, and they come up and they give you a hug and they tell you what you're doing, and I mean that's the fun part.
I can really tell that your students have an affinity for you. I'm actually long-term friends with one of your students, Christian.
Yep.
She now works in an orthopedic surgery practice as a new grad, and she's loving it. And she says that you were one of her favorite profs, and you were very well known for your algorithms.
Yes.
And your hilarious GIFs or GIFs. I'm not really sure how to pronounce it.
I think it's GIFs.
You think? Okay, GIFs. So how did you develop that passion for teaching? Like, what do you love about teaching medicine?
I mean, I think if you all just, anybody who's listening or watching this, you always can think back of who your favorite teacher was. Like, whether it was in elementary school, middle school, high school, college, you all can always think back of who was my favorite teacher. And then you start getting a little deeper and say, well, why? Why was this person a good teacher? Was it just because they did a certain thing? I like to use a lot of humor in my talk because medical education is dull. And so if I can make something fit that's kind of funny, you're going to remember that. One of my very first classes of students went to a recertification conference, and they were learning about diabetes insipidus. And I have a picture, I still have it on my slides to this day, of a dog with their mouth open in front of a massive sprinkler. And I thought it was funny, so I put it on there, and she still remembers that. Like, she sent me a picture from the conference, and she said, why is it the only thing I can think of right now is a dog with their face in a sprinkler? And I said, that's the method to my madness. Mm-hmm. So if I can find things that make that resonate, you're going to remember that. And if you remember that, now it's starting to fire on the neurons a little bit for you to remember the material that I taught. And it's not just words and phrases and those kind of things. That's to me part of being the art of a teacher. And algorithms just make sense in my brain. Clinically, emergency medicine, everything is algorithmic driven. If it's this, then it's that, and then it branches here, and then I order this, and then if that's positive, I do this. So anytime I can get those in my teaching, I try to, because I can take a 40-slide, 2-hour presentation, and I can distill it down to one algorithm. Now, if you just took that algorithm, you wouldn't know what to do, because there's a lot of details behind the scenes that we just spent the last 2 hours covering, but that algorithm is what you need to remember. So if you can learn all those bits and pieces and then be able to go to the algorithm and understand it, that's all you need to know. And so that's me personally. That's how I learned. So I tell them up front, I said, look, I love algorithms, so you're going to love algorithms. There's no way around that. I'm your teacher. I'm going to force it to you. But then as they get a little bit more advanced, they start to understand the method of that madness.
All right. And a lot of us that are clinicians also try to take on students to precept, and some of us go on to teach formally within PA programs. We kind of go back to our alma mater, which is what happened with you.
Right.
So a lot of us don't learn how to teach. So what tips would you have for PAs that are interested in teaching in a more formal setting at a PA program?
So if you're out practicing and going into academia, something that you might be interested in, the first thing you should try to do is reach out to if it's feasible, reach out to the program that you went to, because a lot of times they'd love to have former students come back to give some guest lectures. If that's not feasible, if you moved across country, then I would say reach out to the PA programs that are in your area and just ask them if they're looking for any content experts, because 9 times out of 10, if you're a hematology oncology PA, there's probably not somebody in their practice that does that, and they would love to have a PA with that area of expertise. If that doesn't work, you reach out to your state organizations, because they're typically always looking for speakers, and then you start, again, dipping your toes in the national scene and start submitting talks to the AAPA or to CAPA or to some of your specific organizations and the subspecialties that you work in. But it's basically, you just got to start. You can't really expect to leave one area of expertise and be able to jump right into being an effective educator. It fails more often than it succeeds. So you have to go into it understanding, look, I'm not going to do well for a little while, and there is a learning curve. I tell all of my faculty it takes about 3 years to get comfortable in being a PA professor, because you have to design the course, you have to design your PowerPoints, then you have to give it, then you have to say this is awful, so let me revamp it, and do that 2 or 3 years in a row. Then you get to the point where your slides are good and your PowerPoint's solid. Now you can start honing the craft of the actual speaking. And I've been doing it now long enough that the slides that I developed when I first started are still the slides that I'm using to this day, and I have them memorized. So I can walk the classroom and I know the slide that's coming next and the slide that's coming next. So if you listen to me talk, it's a very fluid process. New educators are tough because they're so, they're reading the PowerPoint slides word for word. They don't want to leave the podium because that's their safe space. So it's just getting comfortable with it. And you want to do it in an area where it's okay to be bad because you're getting experience. So do it in a safe place. Contact programs, contact your state organizations, and start to, because you may think that you want to teach, and then you give one talk and it was the most utterly terrifying thing that you've ever done. Just think about having to do that every single day. If that's not something that you can get over mentally, then maybe that's not the right profession for you. So it's just get experience. That's all it is.
Mm-hmm. And you had mentioned that you started precepting PA students on the trauma or burn ICU as an elective rotation in your first year of clinical practice.
Yep.
So the word got out, you were amazing, so your alma mater called you back and asked you to come back and teach.
Right.
So often more than not, I find that PA providers who take on clerkship students want to ensure that they get the most out of their rotation. Mm-hmm. So what tips would you have for integrating a PA clerk into a practice?
Yeah, really what you have to look at is you need to look at what area of medicine that you work in. So if you're in emergency medicine, then what you can do is you can go to, at least in the United States, we have the PAEA, Physician Assistant Educator Association, end of rotation exams, and a blueprint of the topics that are covered on that examination. So as with everything in education, you can't assess something unless you have an objective. So now you have the competencies, you have what needs to be covered during this rotation. Now you can start integrating that into the daily fold. If they saw something that's on the blueprint, have them present it to you. If they haven't seen something, maybe you tell them, go home and read up on it and come in and give me 3 things that you learned about it. Maybe you have them give a formal presentation to the other PAs, nurse practitioners, or physicians in the group about a bigger topic, headaches or chest pain or something. Make them learn, but give them a space to be able to do it in, and as well as having just those little tiny nuggets throughout the day of, you're reviewing the labs with somebody and you see that they're hyponatremic. And you say, well, what's the number one cause of hyponatremia? And some people call it pimping. I still like pimping. I think it's good in the right settings as long as you do it in a safe space. That's fine. But that's where those little tiny bits build up over time, and the student will then enjoy that because they're learning and they don't know that they're learning. If they go to a rotation where the preceptor really is not all that interested, then they're basically just going to see the patient, present the patient. They're going to say, okay, fine, go see the next one. And it's much more of a drudgery, and it's much more of a job, and they've got to then go home and do all the learning on their own. So if you have that mapped out and you have a process of what you want to cover, then it's going to beget the student enjoying being on service, which is then going to make them being on service more fun for you to precept them. So it's really just getting a plan of what do you want the students to learn. I mean, we could probably do a whole nother episode on what I tell students to do when they show up on service. I tell them to, you want to give your preceptor 3 things that you want to learn or accomplish, and then you want to say, if I had one thing, the one thing I want to do in emergency medicine, what is it? Because if they tell me that, then it's my job to go out and try to find that. If they come in and say, look, I really want to be able to do a lumbar puncture, then I'm going to seek out a patient who a lumbar puncture is appropriate for and then get them to do it. But if they didn't tell me that, I wouldn't know it. So it's our mentality of being that preceptor, of trying to draw the student out, of saying, look, I want to make this as fun as you want it to make it, and you need to map that process out.
Mm-hmm. So what draws you to emergency medicine?
I like to learn a little bit about everything. I'm not very good at diving into one thing and knowing it all the way through. I like to know a little bit about everything so that, if I'm talking with somebody, I can at least sound like I know what I'm talking about. It may be a very small sliver, but at least I know enough about it to be able to manage it. And that's the fun part about emergency medicine. I mean, somebody said, I think it was Joe Lex, had said that emergency medicine is the most interesting part of every single subspecialty, because we need to know about all of these catastrophes and life-threatening. Like, we don't have to manage the little tiny stuff on a day-to-day basis. We need to be able to take, a woman who's 32 weeks and is having 3rd trimester bleeding and be able to manage that. I don't need to manage them when they're 12 weeks, 16 weeks, and I'm giving them their glucose loads and all that other stuff, but that's the fun part of emergency medicine. So you have to embrace that. It's very high stress. It is very much life or death, because these patients are coming in very, very sick, and you're going to have 15 balls in the air that you've got to be able to juggle, and you have to risk stratify, and you can say, okay, this person can wait, but this person can't. Let's discharge this person. Okay, I'm going to go suture this one up while I'm waiting for the labs on this one, and my brain works very, very well from that, and everybody that I know that's in emergency medicine is wired very similarly.